Hello, everybody. I'm Andreas Reimann, and I welcome you to this second webinar of the Alliance for Pulmonary Hypertension in 2024. And I'm very happy that we can continue this series of webinars on progress in PH treatment, driven by the guidelines that have been published recently. Today, we are talking about the treatment of chronic thromboembolic pulmonary hypertension. We did this last year in November already on a more general pathway, but today we are talking about interventions to treat that complication. And I'm really honored to be joined by two very esteemed speakers. I welcome Professor Hiromi Matsubara from Okayama. And I know, Dr. Matsubara, that it's very, very early in the morning. It's 2 a.m., I think, at your time. And we are very pleased and honored, I have to say, that you made it at that time. And we are also joined by Dr. David Jenkins from London. And we are joined by Rishabh Radhakrishnan. Sorry for having difficulties pronouncing your name, Rishabh. You are a CTEPH patient, and you are sharing with us your patient experience. The Alliance for Pulmonary Hypertension is a non-for-profit organization that devotes resources to the advancement of the treatment of PH and the empowerment of patients living with PH and their caregivers. And I'm very honored that we can have this faculty together. And I just wonder if Dr. Jenkins is already with us. Here we go. Dr. Jenkins, welcome. You're right on spot. I'm Andreas Reimann. I'm moderating this webinar, and we are really very honored that you and Dr. Matsubara are joining us for this afternoon or this morning or this night for this webinar. We will be starting actually with major surgery to treat CTEPH, and I suggest, Dr. Jenkins, that you are starting with your presentation. We'll call up the slides for you.
Sorry?
We will bring up the slides for you.
Okay.
Here we are.
And do you want me to?
Yeah, if you could start your presentation, that would be very lovely. Yeah.
Okay, and to advance the slides, will it be done for me?
Just tell us, it will be done for you.
Okay. Well, thank you very much for inviting me. I was asked to speak about pulmonary endarterectomy surgery for CTEPH, and I'm honored to be included in the webinar. Next slide, please. So to set the scene, I suppose, because I'm aware that not everyone in the webinar is a PH physician. Pulmonary hypertension, the new definition is a mean pulmonary artery pressure of 20 millimeters mercury and a resistance across the lungs of 2 Wood units. And one of the difficulties of diagnosing pulmonary hypertension is there's not an easy accessible part of the body to measure the pressures. So as you can see on the right-hand side there, pulmonary hypertension has to be measured with a catheter, an invasive procedure, which goes from a peripheral vein through the right side of the heart into the pulmonary artery to measure it, unlike systemic blood pressure, which is easily measured by a cuff on the limb. And that's one of the difficulties with this whole disease. Next slide. But over the last sort of 20, 30 years, we've learned a lot more about pulmonary hypertension. And this picture is from the latest international guidelines from 2022. and it shows that there are 5 different diagnostic groups accounting for pulmonary hypertension. And in this talk, we're talking about group 4, and the majority of patients in group 4 have chronic thromboembolism or CTEPH. And this is the group we're talking about today. Next slide. So CTEPH, just to very briefly introduce it, is caused by an obstruction in the pulmonary arteries resulting from a pulmonary embolism, a blood clot to the lungs that's incompletely resolved by the body. In the majority of patients having a pulmonary embolism, the body lyses the clot naturally and they return to normal. But in about 2 or 3% of patients, that process doesn't happen properly, and we don't understand why, and they end up with pulmonary hypertension. One of the difficulties in diagnosing CTEPH, and often there's a diagnostic delay of up to 18 months, is that the symptoms are non-specific with exertional breathlessness and fatigue. And for patients with these symptoms, there are much commoner diagnoses, so the diagnosis is often delayed. And probably only about 3/4 of patients have a clear history of DVT or pulmonary embolism, so that can be a distractor for physicians as well. But it's very important to make this diagnosis because we know in 2024 that there are 3 treatments available for these patients, and CTEPH is the most treatable form of pulmonary hypertension currently. And the treatments are pulmonary endarterectomy, which I'm going to speak about, balloon pulmonary angioplasty, which Professor Matsubara is going to speak about, and then for a few patients who aren't suitable for either, there are some medical therapies as well. Next slide then, thank you. So this is what CTEPH means to me, and this is a montage of the specimens removed by pulmonary endarterectomy surgery, showing all the casts of thrombus from within the pulmonary arteries in the lungs. And this is why we think that predominantly this is a mechanical disease that can be either cleared by surgery or reduced in volume by the balloons to improve blood flow through the lungs. Next slide. So these are the recommendations for treatment from the last World Symposium, and a plug that the 7th World Symposium in Pulmonary Hypertension is going to take place this year at the end of June, beginning of July in Barcelona, and that this treatment algorithm will be updated further with the most modern evidence. But this is the current treatment algorithm, and it emphasizes the importance of making the diagnosis and then discussion with an expert CTEPH team. And the first decision is whether the patient may benefit from surgery or not. And if they do, that's the recommended treatment of choice. But if we don't think they'll benefit from surgery, the next best treatment is the other mechanical therapy with balloon pulmonary angioplasty that we're going to hear about afterwards. Next slide, thank you. And this is reflected in the newest international guidelines, where all 3 treatments for CTEPH get a 1B recommendation for therapy, but the order of treatments should be as we saw in that algorithm, with considering for surgery first, as that's the main recommended therapy. If that's not suitable, going to BPA, and if there are no targets for BPA, to consider medical therapy. Thank you. Next slide. And this is a cartoon showing those 3 treatments and showing across the top there, this is a pulmonary artery, the left pulmonary artery. And this cartoon emphasizes that surgery is better treating the more proximal lesions, the bigger lesions within the pulmonary artery. And then when we get down to the smaller segmental, subsegmental branches, the balloon angioplasty can work. And there's probably a bit of overlap with both mechanical treatments here. And then for the microcirculation, the drug therapies work. So this is explaining really that those 3 treatments act at 3 different places within the pulmonary circulation, but there is a bit of overlap with the treatments. Thank you. Next slide. This is just showing the imaging to diagnose CTEPH and the importance of the imaging with the VQ scan as the screening test, then an echocardiogram, and then accurate mapping of the pulmonary circulation so that the surgeon can decide whether there are targets for surgery, and the angioplasty operator can decide whether there are targets for balloon therapy. And these three important tests with a CT pulmonary angiogram, a conventional pulmonary angiogram, and an MRI pulmonary angiogram can give the technicians the information they need to decide on which is the best treatment for each patient. Next slide. Coming on to the pulmonary arteries and why we need to understand the anatomy and physiology of these arteries when we're deciding on our treatments and when we're carrying out those treatments. And certainly for surgery, one of the difficulties is that the pulmonary arteries are deep within the middle of the chest. Ordinarily, they have up to 5 liters a minute of blood flowing through them. And the thickness of the vessel wall is narrow. It's a thin-walled vessel, the pulmonary artery. And also the lungs have a dual circulation, so they get blood through the pulmonary artery, but also a separate circulation from the bronchial arteries of systemic oxygenated blood from the aorta. And for these reasons, the operation is quite an invasive procedure. To divert most of the blood out of the pulmonary arteries, we go on the cardiopulmonary bypass circuit, the heart-lung circuit that's used for most cardiac surgery, and that diverts most of the blood away from the pulmonary arteries. But because of that bronchial co-circulation, the only way to remove all the blood from the pulmonary arteries is completely arrest the patient and drain all the blood out of the body. And that's what's required to perform this surgery. Next slide. And so this is just showing the heart-lung machine there, which is used for pulmonary endarterectomy surgery. The main difference between pulmonary endarterectomy surgery and standard heart surgery is both require the heart-lung machine, but for pulmonary endarterectomy, we also require to remove all the blood from the patient's body to have a good view into the pulmonary arteries. Next slide. And in order to do that safely, we need to cool the patient down because the brain is very sensitive to lack of blood supply. And by cooling the patient's core body temperature to 20 degrees, that gives us a safe time limit where we can drain all the blood out and preserve brain function. And that means then we have about 20 minutes of safe time to do the dissection in the right pulmonary artery and the same in the left without any blood flow through the patient during that time. And the procedure we use is called deep hypothermic circulatory arrest, which basically means we cool the body down and then we can safely drain all the blood out to give us a good view to do the operation. Next slide. And this is the surgical technique to do the operation. The principle is very simple. We clear the obstructions, and that reduces the pulmonary vascular resistance, and the PA pressure allows the right side of the heart to recover so that more blood can be pumped through the lungs, so the patient gets improved exercise tolerance, less breathlessness, and in the future, a longer lifespan. So the principle is very simple, but the procedure is technically relatively more complex. The approach is a median stenotomy, so it's an incision through the middle of the chest wall, as for any heart surgery, and then on the heart-lung machine, cooling the patient's body to 20 degrees, and then the circulatory arrest. And then while that's happening, we do a true endarterectomy to remove the inner lining of the lung arteries to remove the obstructions. Next slide. This is a little cartoon of showing what we do inside the pulmonary arteries. Next slide. And this is a video very briefly of an operation. This is opening the left pulmonary artery and looking inside. This is raising a dissection flap on the inside of the pulmonary artery wall. You can see here that it's a thin wall, and we're raising a plane on the inside of the artery and gently dissecting that plane around the circumference of the artery. You can see where it starts off, it's very thin, and as it gets the disease further down, it gets thicker. all the patient's blood is drained out of the way now, so we've got a good view. These are removing some obstructions and webs at the origin of some segmental branches. You can see there's a thick core of fibrosed blood clot there. We call these the little tails, and we're gradually dissecting those out of some of the segmental branches and pushing the remainder of the vessel wall back as we remove the obstruction. As you can see there, we're teasing out those long strands. And then removing the whole specimen and showing the inside now all clear. Next slide, we can move on. And these are the outcomes we get. This is from our own data at Royal Papworth Hospital, looking at our series. This was done in around, I think, 2019, and looking at the patients over time there. And we can see over time from cohort 1 to 4, our outcomes have steadily improved, and it gives a dramatic reduction in mean PA pressure and pulmonary vascular resistance. As you can see, the mean PA pressure halving after surgery there, and the pulmonary vascular resistance reducing by almost 2/3 there. And in the risks of surgery these days are relatively low, with the latest mortality risk at 30 days there less than 2%. So the risk has become relatively similar to normal standard cardiac surgery now in modern pulmonary endarterectomy practice. Next slide, thank you. But there are some complications of this surgery, and the standard complications of any operation, which can usually be treated and dealt with. And then there are 4 sort of more specific serious complications with this surgery, and listed there, where there can be a bleed into the airway after surgery. There can be reperfusion, lung injury to the lungs after surgery. Some patients have more residual pulmonary hypertension and right heart failure than we would have expected. And occasionally there can be neurological injuries and strokes. The majority of those complications can be helped now, if they're very severe, by ECMO support, which is a circuit outside the body to temporarily take over the work of the heart and lungs whilst they recover. And that has probably halved the mortality risk of pulmonary endarterectomy surgery in modern practice. Next slide. And this shows that the trial that we performed at Royal Papworth Hospital over 10 years ago now, to show that cognitive function is preserved despite the circulatory arrest required to do this surgery safely, and brain function and cognitive function does not decline following this operation. Next slide. And this shows from the latest international registry data the effect really of the mechanical therapies on patients with CTEPH. This is survival over up to 5 years following surgery. And you can see there those patients, the red line are the patients who had surgery, the green line are the patients who had BPA, and the blue line are the patients who had drug therapy, but none of the mechanical therapies. So you can see that the survival of the mechanical therapies, the surgery and the BPA, is in the order of sort of 90%, but the survival of those who don't have the interventions is down at 70% there by 3 to 5 years following diagnosis. So this really emphasizes the importance of the interventional therapies for CTEPH. Next slide. And this again is from our own data at Royal Papworth Hospital. And this shows the improvement in activity, quality of life, and symptoms from a CAM4 score, looking at those factors in patients before and after pulmonary endarterectomy surgery. So in the CAMFOR score, a low score is good. That means patients are happier with good quality of life and fewer symptoms. And you can see a significant reduction in all the scores across all the parameters following surgery by 1 year afterwards. But more importantly, this benefit is sustained up to the 5 years. So it shows a dramatic improvement and a sustained improvement following surgery. Next slide. So in conclusion, ladies and gentlemen and patients listening, I think the role of pulmonary endarterectomy is clear for this disease. It is the guideline recommended first-line treatment for CTEPH. And in all the modern registries, accounts for the majority of interventions. Approximately 60% of patients with CTEPH go on to have pulmonary endarterectomy surgery. The operations these days is reproducible with a small but definite mortality risk of up to about 2% in experienced units. So it's not dissimilar from standard cardiac surgery. There's an improvement immediately in the hemodynamics. There are some specific serious complications, but they can be treatable and patients can benefit from the ECMO support. And these successful early outcomes translate into a sustained improvement in quality of life for patients and better long-term survival. It can be part of, the surgery can be part of a multimodality strategy for some patients who may require all three treatments, but for the majority of patients, it's the only treatment required. Next slide. And thank you all for your attention. I'm happy to answer any questions afterwards. Thank you.
Thank you very much, Dr. Jenkins, for this fascinating presentation, for the absolute fascinating figures you showed us, and the improvement over time of that intervention. We will have time to discuss this, and I like to encourage all viewers and participants in this webinar to write their questions into the chat. Use the chat function of the platform you're using, of YouTube or Instagram or LinkedIn, and then we will be able to see them and to discuss them at the end of the presentations. Now I'm really very honored to invite Professor Matsubara to talk about an alternative, I shouldn't probably say an alternative, about an additional way of treatment for some patients, which is called balloon pulmonary angioplasty. And Professor Matsubara, if I'm not mistaken, you are really the pioneer of this intervention, of this micro-invasive intervention, minimal invasive intervention, and we are very honored that you're going to present the insight about that. Please, the floor is yours.
Thank you. So next slide, please. So these are my disclosure. So next slide, please. So Professor Jenkins already talked about the CTEPH, but I'd like to emphasize that CTEPH is a rare complication of acute pulmonary embolism, but stenosis or obstruction of pulmonary artery in CTEPH caused by organized thrombus. Organized thrombus is not merely clot. It's a tissue like in the right panel. So anticoagulation or thrombolytic treatment is no longer effective to treat CTEPH. The gold standard treatment for CTEPH is to remove these tissues from inside the pulmonary arteries by surgical procedure. So the PEA is the first-line treatment for CTEPH. However, about half of cases in the international registry, the patient could not done PEA because of the distribution of the regions or patient's age or other comorbidities. So patients diagnosed as inoperable has had no mechanical treatment previously. So next slide, please. The BPA is interventional technique to treat CTEPH cases. For example, in the left side panel, you can see the stenotic region at the arrowhead, and in the center panel, using the balloon dilation, the region could be dilated, and immediately after removal of the balloon catheter, you can see the region distal flow restored. So it's very simple technique to treat only one or two regions. But CTEPH had usually CTEPH patients had many regions all over the pulmonary arteries. So we have to repeat it to the almost all segmental arteries. So next slide, please. We refined the BPA technique, but originally it was reported already in 1988, more than 30 years ago. At that time, only a case report. And next slide, please. First case series was reported from United States. Dr. Feinstein et al. Reported results of balloon pulmonary angioplasty in 18 cases. They performed average 2.6 procedures and 6 dilations for each patient. Mean pressure decreased from 43 to 33.7 millimeter mercury, but about 60% of patients developed complication, the severe complication after the procedure, and one patient died. So for inoperable cases, it appeared to be an attractive treatment option, but at that time, because of too high complication rate and too low efficacy compared to PEA, this technique could not be spread to the world. Next slide, please. But in Japan, because we didn't have an experienced surgeon, and the outcome of PEA was terrible at that time. So we decided to refine this technique in 2004, and reported our initial experience in 2012. At that time, 68 cases had been already treated with average 4 procedures and 12 dilations. It was almost doubled compared to the initial report. And we could decrease mean pressure from 45.4 to 24 millimeter mercury, but 60% of patients developed severe complication after the procedure. Please click. Click the slide, please. Okay. So the decrease of mean pressure was totally depending on the number of treated segments. So it was natural that our results were much better compared to the initial report, because we performed almost double procedures and treated double segmental arteries. Next slide, please. But at that time, we tried to dilate the region as large as possible. So use a bigger balloon from the initial treatment. For example, in this case, we treated the right lower artery and also the right upper lower artery. After dilation, you can see the flow and immediate return, venous return. However, next slide, please. After the treatment, patients developed a lung injury. As you can see in the front center panel, the patient lung showed infiltration immediately after the procedure, and the patient need to be intubated and need a mechanical support to maintain saturation. In such cases, usually patients develop the blood sputum, and the CT images show the bleeding around the dilated site. So, aiming for complete dilation from the beginning of the region that may cause pulmonary injury due to hemorrhage from vascular injury. To prevent this, we have to use a smaller balloon, especially in case with a high mean peer pressure patient. So next slide, please. One click, please. PEA surgery could improve from pulmonary artery flow in all segments within only one procedure. However, one click, please. BPA, if we do like PEA, patients will develop severe lung injury. So the initial treatment, we just treat stenotic regions of the unilateral lung. And the next click, please. Then for the second procedure, opposite side of lung treated a bit larger balloon and wait 1 month or 2 months and click, please. One click, please. For the third procedure, we repeat the treatment and also treat the totally occluded regions with a bigger balloon to completely normalize the segmental flow. And one click again, please. And finally, we treat the opposite side. So stepwise dilation like this is necessary to achieve the final results comparable to PEA. So next slide, please. For example, in this case, initially the patient's mean peer pressure was 61, and one click, please. After one procedure, we treat GS regions, and the patient's mean peer pressure could be decreased to 46. And again, click, please. And after second procedure, patient's mean peer pressure could be about half of the baseline value, and wait 1 month and click, please. Again, treat mainly right side, and again, click, please. And finally, we finalize the treatment by treating left side, mainly left side, and the patient's mean peer pressure could be less than 19 with only 4 procedure of BPA without causing any complication. Next slide, please. So before procedure, you can see many stenosis or occlusion they exist, and distal flow are limited. The lower panel show the perfusion imaging. There are numerous defects, but after completing the 4 procedures, patient's PAG became almost normal, and the perfusion scintigram also improved much. So next slide, please. But BPA is an interventional treatment, so minor, but still invasive compared to medical treatment. So I'd like to show what is the difference between the medical treatment and the BPA. So this case was enrolled in the randomized study comparing riociguat, the medical drug to treat CTEPH, versus BPA. And this patient randomized to the riociguat group. So for 1 year, patients treated with riociguat. And after 1 year, PAG was almost the same as the baseline. And the perfusion scintigram, the lower panel, showed a bit better perfusion. The better perfusion in this image could be shown by the green or yellow area. Mean peer pressure could decrease about 5 millimeter mercury and 6 minutes walking distance increased, but the saturation almost the same. One click, please, and another click, please. Oh, no. Sorry, return. Another click on the image, yeah. So after BPA, as you can see, the pulmonary angiogram became almost normal, and the perfusion scintigram showed a much better perfusion compared to 1 year after real cigarette. Patient's mean peer pressure could additionally decrease about 50 millimeter mercury, and most remarkable difference is saturation. So oxygenation could be also improved after BPA. So not only the hemodynamics, but also the saturation, oxygenation could be improved by BPA. So after the treatment, patient symptom would be much better compared to receiving only medical treatment. So next slide, please. So previously, the Japanese centers performed the registry only in Japan, but multi-center registry showed a significant improvement of functional class and hemodynamics, and decrease of mean peer pressure immediately after the BPA was of course obtained, but it was maintained at follow-up. And at that time, patients' 3 years survival rate was about 90%. So next slide, please. So in 2012, only 2 countries, Japan and Norway, performing BPA as a treatment for CTEPH, but click please. 10 years later, so many countries following our success, and now it became a treatment option, and the current guideline recommended BPA for inoperable CTEPH cases. Next slide, please. So this slide shows the global outcome based on the multi-center registry and the prospective randomized study. Our results show that the mean peer pressure decreased about 50%, and PBR decreased about 65%. But European registry performed in Poland showed that the mean peer pressure decreased about 30%. So it was probably based on the difference in the experience. Indeed, after experiencing many cases, current prospective randomized study from Japan and from France showed almost the same results. Mean peer pressure decreased about 40%, and PBR decreased about 60%. And please note that 30-day mortality previously in Japan 2.6% and in Poland 1.7%, but in the randomized study in France 0%, and Japan also no one died. Next slide, please. So as a summary, BPA was born in 1988 and grew up in Japan. So we just refined the BPA technique, and the safety and the efficacy of BPA has been established, and BPA is accepted globally as a treatment option for inoperable CTEPH patients. Thank you for your attention.
Thank you very much, Dr. Matsubara, for this delightful presentation. I mean, you showed us that there's a dramatic improvement in the outcomes, and there are excellent outcomes, and we're very happy that Rishabh Radhakrishnan is a patient who underwent BPA, and Rishabh, you want to share with us your experience. Please go ahead. just to remind everybody once again, if you have questions to Dr. Jenkins, Dr. Matsubara, and now to Rishabh Radhakrishnan, please feel free to do so and key them in your chat. Go ahead, please.
Okay, thank you, Andreas. Hello, everyone. My name is Rishabh. I'm a student at the National University of Singapore. I was diagnosed with CTEPH in September of 2022. And over the next 15 minutes, I'd like to share with you a journey that my family have been through from diagnosis to cure. But just before that, I want to thank Professor Matsubara and Professor Jenkins for all that they've done over the past few years to help thousands of CTEPH and pulmonary hypertension patients like myself. Next slide, please. Okay, so my journey started around July 2022 when I just completed my 2-year army service after high school. Yeah, that's a picture of me with my grandparents before diagnosis. So in Singapore, all men are required to serve in the army after school. And this was by no means an easy experience, but overall it was extremely positive for me. And I had just started my university in August, immediately after the army. And around that time, symptoms started to develop, primarily in the form of exertion intolerance. So I was very passionate about running during my days in the army. I would frequently run 10Ks with ease. And in July 2022, I noticed a steep drop in my stamina, which didn't make any sense to me or my family. And what really frightened us was loss of consciousness one time as I was crossing a road. But fortunately, I was with my friends who helped me. But this prompted my parents and I to seek the help of a pulmonologist. And he initially diagnosed me with asthma and started me on a spray, but this treatment didn't show any improvements. Next slide, please. So yeah, I underwent more testing, and later blood tests and CT tests confirmed the possibility of pulmonary embolism, which we understood were easy to address, although still very concerning. Unfortunately, however, when the right heart catheterization and pulmonary angiogram procedures were performed, my doctors at the time confirmed CTEPH. And as a part of the procedures, various hemodynamic measurements were also taken. So while mean pulmonary arterial pressures, or mPAP for short, of under 20 is considered normal, we learned from the RHC that mine was around 36, which confirmed pulmonary hypertension. And the measurement of cardiac output seemed normal at the time, which cardiac output is the amount of blood that the heart pumps out in a minute. But this was later established to be incorrect and probably lower. So I was started off on anticoagulants and 3 months of observation as per the standard protocol for CTEPH. And yeah, this picture was taken when I was hospitalized during diagnosis in September 2022. Next slide, please. Okay, so the next 2 months proved to be very challenging for me because I tried to lead as normal a life as possible, and I refused to postpone university as well while my symptoms continued to worsen. So this is a picture of me with the FIFA World Cup chart, keeping track of the matches. I'm hugely passionate about football, and I couldn't play anymore as I would be breathless after walking merely half a kilometer, but I could still watch and enjoy football. And the second picture was taken in October 2022. So I was at a restaurant, again, trying my best to retain the life of a normal university student. And you can see how skinny I'd become as a result of the disease. I was around 62 kilos during my time in the army. And in that picture, I believe I was 55. And just for context, I'm 177 centimeters tall. So periodic echocardiogram tests continue to show no signs of improvement to measurements such as the size and shape of my right ventricle, pulmonary pressures, and my stroke volume, which is the amount of blood that the heart pumps for every beat. So I was a very fit person before CTEPH as well, and now my resting heart rate was typically around 90 beats per minute because my heart had to work a lot harder to get the body the oxygen that I needed. So my parents and I spent a lot of time understanding my treatment options and the possibility of either a PEA surgery or the BPA procedures. In fact, at the time, we had reached out to Papworth Hospital and discussed my case with one of Professor Jenkins' colleagues. And Papworth's assessment was that I was a good candidate for PEA, but we started to consider the BPA as our preferred option. So towards the end of November, just over 2 months since diagnosis, I experienced a sudden deterioration of symptoms. I would get out of breath walking barely 50 meters at a very slow pace. I had a couple more instances of losing consciousness when exerting. Even tying my shoelaces would make me feel lightheaded. And I also developed a new symptom characterized by the hoarseness of the throat, which is known as Ortner syndrome. and Altman syndrome is considered very rare in CTEPH patients. It's caused due to the compression of my left laryngeal nerve, and as a result, my voice became very hoarse. I could only talk softly, and it felt as if I had a permanent sore throat. Next slide, please. Yeah, so due to this sudden deterioration of symptoms, our doctors in Singapore and I agreed on acceleration of next steps, and we made the decision to go ahead with BPAs. So our decision on treatment option was driven by two factors. Firstly, the PEA is a major heart surgery, as Professor Jenkins explained. There's a long recovery process, while the BPAs, on the other hand, are multiple interventional procedures requiring just overnight hospital stay and immediate recovery. And secondly, my parents and I felt that published data showed comparable results between the PEA and BPA, but it's very important for me to emphasize that this was just our personal opinion and preference based on what we had read at the time. Yeah, this is a picture of me after my first BPA when I had regained consciousness from the sedation. At that point, my parents and I were extremely hopeful that my recovery would now commence. We had no idea at the time how bad the next couple of months were going to be. So subsequently, 4 BPAs were performed between November and January in Singapore. And there were brief moments during these months that I experienced small improvements, but the symptoms would always deteriorate again. So through all 4 BPAs, my mean pressure was measured at between 45 and 50, and stroke volume measurements through echocardiograms also showed no improvements. And my resting heart rate continued to be around 90, and it would shoot up upon light exertion, such as walking. Next slide, please. Yep. So at the end of my 4th Singapore BPA, we took some more hemodynamic measurements, and they looked very bleak. My MPAP was 44, and I had very low readings for cardiac output as well. And at that point, the prognosis didn't look too great. So my doctors back then advised possible microvasculature as a reason for no improvement, which is when microvasculature is when CTEPH impacts very small blood vessels that even a BPA can't address. So at this point, the options were extension of life by a few years through medication, or the very extreme option of a lung transplant. And my parents, who I'm of course so thankful to, they conducted extensive research since my diagnosis. Naturally, they were extremely worried, and they did everything they could to try and find a solution. My father in particular spent sleepless nights reading research paper after research paper. Towards the end of January, my father reached out to the Okayama Medical Center, requesting an urgent video consultation with Professor Matsubara. So we had known about Professor Matsubara as well as Professor Jenkins and their expertise in CTEPH almost since diagnosis, but it was only now that we had finally contacted Professor Matsubara, and we felt the BPAs were the best solution for us. And he was very kind to give us time for an urgent consultation, as my condition was quite grave. We requested him to take me as a patient and consider me for his BPA treatment. And based on his evaluation of my reports and scans, he felt confident that he could restore me to at least near normalcy. And at that point, my parents and I felt elated. It felt like we had been drowning, and Professor Matsubara had given us life jackets. So within weeks, we were on a flight to Okayama for treatment in February of 2023. Yeah, so this is a picture of me on my flight to Okayama in February. It's a bit difficult to see, but I've got oxygen going into my nose via cannula. And that this is Professor Matsubara's recommendation as precaution for high altitudes. So the last couple of weeks before our trip to Okayama in February, there seemed to be minor improvements in symptoms, and we even wondered if the Singapore BPAs had started to gradually work. But from the date of travel to the next day when I was admitted at the hospital, symptoms deteriorated rapidly again. Each time I experienced some improvements, it felt like pushing a ball up a slope. If you let it go before getting to the top, it would start rolling down again. So I remember the morning I was about to get admitted into the hospital, I nearly lost consciousness while tying my shoelaces in the hotel. Next slide, please. So I was admitted to Okayama Medical Center for 4 days, during which Professor Matsubara and his wonderful team performed 2 BPAs. And the hemodynamic measurements at the end of those 2 BPAs were dramatic. We immediately saw a 30% drop in mean pressure and a huge jump with complete normalization of stroke volume and cardiac output. Until discharge, of course, I couldn't really test how I felt after the procedures when exerting, even though measurements were unbelievable to my family and I. But right from the point I stepped out of the hospital, I noticed an incredible improvement in my symptoms. I actually didn't feel anything with normal exertion, such as brisk walking and gentle slopes. This picture of me is in Osaka just one day after discharge. And I remember my dad and I going for a long walk at a brisk pace, and it was incredible. I felt completely normal. So yeah, normally we take for granted the amazing system in our body from the point we take a breath to the point where the oxygen is delivered to our muscles, organs, cells. But here I was actually experiencing the significance of this incredible process. So after returning to Singapore, we tried out stairs, and my parents were extremely nervous, naturally. But I felt absolutely nothing. I was completely fine, completely normal. My resting heart rate had also normalized, and it dropped to a healthy 60 beats per minute. So I could do normal life stuff at this point, normal life stuff that a typical young person would do, such as climb stairs, 2 steps at a time, sprint to catch the bus to university, walk to my classes. The only constraint was that I had been advised to not commence exercise as my treatment was not yet completed. Next slide, please. Okay, so we returned to Japan in May as planned for additional BPAs, and I've been feeling amazing since my February procedures. After so many stressful months, my parents and I also had a holiday in Tokyo and Kawaguchiko near Mount Fuji, and as Kawaguchiko is at an 800-meter altitude, my parents were worried if I would feel any discomfort since there's reduced oxygen saturation at high altitudes. But thankfully, I was completely fine, and we had a wonderful holiday there. Then we headed back to Okayama for my final treatments. And the measurements taken before the start of the procedures showed complete normalization of my pulmonary pressures. Professor Matsubara, in some of his papers, describes this as the spontaneous enlargement of pulmonary arteries after BPAs. And I could literally see it in the measurements and feel it through symptoms that had completely vanished. So my mean pressure had dropped from 45 to 50 in during diagnosis to 33 in February and 19 in May. So at this point, my pulmonary pressure as well as cardiac output were both already within normal levels while at rest. And after 3 additional BPAs in May, my mean pressure further dropped to 16. And as we returned to Singapore with my right ventricle shrinking to normal size, the hoarseness of my voice also fully normalized. And thankfully, there had been no permanent damage to the laryngeal nerve. Next slide, please. Yeah, so how am I doing now? Well, you can see me playing football at university, which is perhaps what I missed most when I had CTEPH. I now work out, study. I had an internship in December, and I have another one lined up over summer. And of course, I enjoy hanging out with my friends, going on holiday with my family. And additionally, the only medication that I continue to be on is anticoagulation, warfarin to be specific. I also underwent physio with the heart and lung physio in Singapore, and my physiotherapist, Jacqueline, was extremely helpful in getting me back into running. These pictures are essentially mementos of me leading my normal life after 4 BPAs in Singapore that have failed, and then 5 in Japan that saved me. Next slide, please. Yeah, so over here you can see a picture of my parents and I with Professor Matsubara at dinner when he visited Singapore. He particularly enjoys chili crab in Singapore, which is what Singapore is famous for. Since Professor Matsubara is on his webinar, I just wanted to say my family and I will forever be grateful for you, not just saving my life, but giving me back a normal life as a young person. I wanted to conclude by telling all CTEPH patients who are watching this webinar to not lose hope. CTEPH is, of course, a horrible condition that robs you of the smallest pleasures in life, such as going for a walk or visiting restaurants with your friends, and it also has a deep mental impact on not just the patient but also the family. But there is hope. As long as you find the right doctor to treat you, there are solutions such as the BPA or PEA to significantly improve the quality of life and even be completely normalized like me. And lastly, I wanted to express my gratitude to the Alliance for Pulmonary Hypertension for inviting me to share my experiences over this webinar. Thank you so much.
Thank you so much, Rishabh, for sharing your story with us. And this is really impressive. It really adds from a patient perspective to what Dr. Jenkins and Dr. Matsubara for sharing with us. We have a few minutes left only for questions And actually, you mentioned that you had 4 interventions in BPAs in Singapore without success. You had 5 in Okayama with success. And we actually do have a question by Louise Baumann van der Waal. She's asking, after how many BPA procedures on average people feel the difference on quality of life? Dr. Matsubara.
Oh, sorry. Sorry, I didn't listen. I just reading the.
No problem, no problem. We have a
Sorry.
question after how many, no problem, sir. After how many BPA procedures on average people feel the difference on quality of life? If I understood Rishabh correctly, please, Rishabh, chime in if that's wrong. You saw this after 2 BPAs already.
Okay, thank you. Thank you for your question. Usually, the initial 1 or 2 procedure show the greatest effect on quality of life. And as Rishabh said, usually after discharge from the initial admission, patients already performed the 2 procedures. And after that, almost all patients realize that their shortness of breath disappear and can do everything like before.
Okay, thanks very much. We actually have another question by Louise Baumann van der Waal. Although you mentioned no cognitive effect of this procedure, I hear a lot of people suffering with concentration problems for a long time after the procedure. Do you know any numbers of the issue? And I think this question goes to both. So if you, Dr. Jenkins, if you could start and then Dr. Matsubara.
Yeah, yes, thank you. Temporarily after any major operation with a general anesthetic, if patients are on analgesics and things, they can have difficulties with concentration early on after major surgery. But we did the definitive randomized trial of pulmonary endarterectomy and cognitive function back in 2011 and was published in the Lancet journal. And we looked at blinded, very detailed cognitive assessments. And we looked pre-surgery, at 3 months after surgery, and 1 year after surgery. And actually, across all the groups, patients were better at 1 year after surgery compared with what they were before surgery. So cognitive function improved, and to do the complex cognitive function tests, they had to have good ability to concentrate. So we think it's related to improvements in hemodynamics and oxygenation. So patients by 1 year had better oxygenation and better blood flow to the brain, and their cognitive function was actually better following surgery than before surgery. So in our practice, with our protocols, we don't really see patients with impairment of concentration, especially in the longer term. It doesn't seem to be an issue. Thank you.
Thank you, Dr. Matsubara.
Yeah. So from the beginning, because we have no previous data before us, so we routinely performed right heart catheter every year until 5 years, and after that, repeat at 10 years after the treatment. And based on our experience, not yet published, but our experience shows that once improved hemodynamics could be maintained at 5 years and probably at 10 years. Because 10 years, not all patients performed right heart catheter, but 5 years, almost all cases received right heart catheter and confirmed that no deterioration observed. And regarding the functional class or 6 minutes walking distance, 15 years after the procedure showed a bit deterioration. The short became shorter, but probably because of age. Because at the treatment, patient's age average 60, currently 65 years old, and 15 years, meaning that 80 years old. The 6 minutes walking distance, of course, shortened, but daily life, of course, maintained. And so if the patient sufficiently treated with anticoagulation, even after the treatment, no recurrence or no deterioration could be observed. So the most important thing is to achieve the best result immediately after the procedures.
And it was a question from myself. There is a question from the PH Singapore, from Melissa Chan. Amazing work. Question for Dr. Matsubara or Dr. Jenkins. Any hypothesis on why the BPAs in Singapore were unsuccessful for Rishabh? May I add my question? How easy it is for patients to find right centers doing PA or doing BPA in the world? I mean, not every patient, of course, is lucky to go to your centers. So how easy is it to find the right centers? Dr. Jenkins, probably you want to start?
Yes, that's a difficult question, really, and it's about access to treatments. Ideally, all patients should have the best treatment in the most experienced centers, but sadly, that's not always possible. We give opinions on lots of patients from around the world about having surgery. Some do travel to Papworth at Cambridge to have their operations, and we're happy to do that. But unfortunately, it's only those with financial resources can do that. In the UK, we have a National Health Service, and all our own population have access to treatment for free. But for international patients, that isn't available. So we are happy to offer surgery to any patients around the world, and we give opinions on many patients for free. But if they come for surgery, the hospital has to charge for that expensive surgery, and we're not a charity. And that means that some people sadly don't have the resources to travel to the UK to have surgery. We're trying, with myself and Hiromi and lots of the experienced CTEPH operators around the world are trying to educate and help starting centers. I have been twice to Singapore and operated on patients in Singapore on 2 occasions to help the team there learn to do the pulmonary endarterectomy surgery. And like Hiromi, I've been to lots of places all around the world. I was in Sydney last month helping the surgeons there with this operation. So we do our best, but it's about trying to educate doctors as much as we can. The difficulty is a lot of these procedures are technically quite demanding, and experience counts, and the best results are obtained from those people who've been doing it for 20 years or so and are doing multiple procedures every week. And there's no easy answer to that, I'm afraid.
Dr. Matsubara, also the question, why didn't it work in Singapore? Why did it work in Okayama? I appreciate that may be a very hard question to answer.
I think I probably answered that as well for him to spare his blushes. Hiromi is a much more experienced BPA operator than the teams probably in Singapore.
Right.
Yeah, probably that. But only one thing I can say is if you decide to receive BPA in your country, please ask the doctors how many cases you have treated until now. So for us, the initial 100 cases are necessary to develop our technique. But nowadays, we already published our experience, and probably not so many cases are necessary. But at least I think 100 procedure. It's meaning that at least 25 cases experience would be necessary to complete the BPA.
Right. Thank you very much for your insights, for your time at this early morning hour, Dr. Matsubara, for you.
No, midnight.
Oh, it's midnight. Okay, but then it's very late if you so wish. We really appreciate your time. Unfortunately, we are already over time, but I think it was quite certainly worthwhile. I'd like to invite the audience to watch out for our third webinar this year on May 28th, and this will be about congenital heart disease and pulmonary hypertension with Professor Maurice Beghetti as a speaker. And with that, I'd like to thank you all for listening in and for presenting, and wish you a very nice rest of the day. Thank you.
Thank you.
Thank you. Sleep well, Hiromi.
Thank
Bye-bye.
you. Bye.